بسم الله الرحمن الرحيم. Pneumocystitis pneumonia (PSP). The definition: PSP is the clinical syndrome of pneumonia resulting from infection with the fungus Pneumocystitis jirovecii, previously termed Pneumocystitis carinii. Pneumocystitis jirovecii is widespread in the environment and most people are infected by the age of 2 years. PSP is thought, however, to follow new infection rather than reactivation of latent infection. Most cases of infection are likely to be person to person airborne transmission rather than environmental. The causes: risk factors for pneumocystitis pneumonia include HIV infection, particularly with the CD4 count below 200 million per liter, treatment with chemotherapy, especially fludarabine, corticosteroids, or other immunosuppressive agents, and malnutrition in children considered as risk factors for pneumocystitis pneumonia in addition to HIV. The neutropenia does not appear to be a particular risk factor. PSP occurring in the setting of AIDS is associated with both a greater number of organisms and fewer inflammatory cells in the lungs when compared with infection associated with other causes of chemotherapy. Pneumocystitis pneumonia is much less common following the routine use of cotrimoxazole prophylaxis in HIV and post-transplantation. Although cases still occur, such as in patients presenting with advanced HIV or in those non-compliant with prophylaxis, the threshold steroid dose for predisposition to pneumocystitis pneumonia is unclear, although a dose equivalent to 16 mg prednisolone or greater for 8 weeks appears to significantly increase the risk. The risk is likely also to reflect the underlying condition, such as pneumocystitis pneumonia, which develop in patients with hematological malignancy taking as little as 5 mg prednisolone daily. Pneumocystitis pneumonia often appears to be present as immunosuppressant drugs doses are tapered or increased. Tapered or increased. The clinical features. Clinical features of pneumocystitis pneumonia: gradual onset of dry cough and exertional breathlessness, sometimes with retrosternal tightness. There are fever and tachypnea. Chest examination is typically normal, may present with pneumothorax. Extrapulmonary disease is very rare. The investigations of pneumocystitis pneumonia: chest X-ray pattern is classically of bilateral perihilar infiltrates that progress to alveolar shadowing. Less common patterns include small nodular infiltrates or focal consolidation. Chest X-ray is normal in about 10%. Pleural effusions are very rare. CT is not routinely required, except in cases of a normal chest X-ray when it may demonstrate a bilateral ground glass pattern or cystic lesions. Hypoxia is common. Desaturation on exercise may suggest the diagnosis in at-risk individuals with normal saturations at rest. White blood count is usually normal. Serum lactate dehydrogenase (LDH) is typically raised. It is sensitive but not specific. Beta-glucan is a component of the fungal cell wall and can be raised in blood or bronchoalveolar lavage, but is not specific to pneumocystitis pneumonia. Induced sputum had a diagnostic yield of 70 to 80% in HIV infection, but is much less sensitive when performed in the settings of non HIV immunocompromised where the organism burden is lower. It should not be performed on the open ward or outpatient department. Bronchoscopy with bronchoalveolar lavage is the diagnostic investigation of choice in non HIV infected patients and in patients with HIV in whom induced sputum analysis is non diagnostic. Bronchoalveolar lavage with silver or immunofluorescent staining has a specificity of nearly 100% and sensitivity of 80 to 90%. The sensitivity is lower in non HIV infected immunocompromised patients, reflecting their lower pathogen loads. PCR is highly sensitive but not specific and cannot tell the difference between infection and colonizations. Bronchoalveolar lavage PCR for BCB has good negative predictive value. Transbronchial lung biopsy has a slightly higher sensitivity, around 95%, but is associated with an increased risk of complication, so is reserved for cases where bronchoalveolar lavage is non-diagnostic. Surgical lung biopsy may be required for diagnosis in a minority of HIV negative patients.